So thank you for having me. I was here last year and happy to be back. I just want to say for everyone who's here, there's archives online. They're really useful. Just a plug for that. If you ever want to see some of the experts in the field, how they do things, it's a really great option. So I was asked to do below-the-knee interventions, toolbox, and rise of alternate access. And to be honest, I don't really know, what the toolbox is. I know what I do. And the cool thing about below-the-knee interventions is it's expanding, every single day. Everyone has different techniques. This is how I do it. This is how I approach it, but I will discuss some of the other methods. So first, we want to talk about treatment to the level based on the symptoms that the patient has. Claudication, typically, if a patient's coming in and just has pedal disease or tibial disease, you're not going to be fixing their claudication by intervening on those lesions. However, rest pain, tissue loss, or even outflow issues is when you really want to touch up the tibials. And you want to tailor your approach based on this level of disease. In terms of the treatment options that we currently have, I think endovascular has generally become the first option for most of these patients, at least to get a diagnostic angiogram, and that includes angioplasty with or without atherectomy. And the data for atherectomy, like Dr. Lentis was talking about before, and most of these interventions is based off of not always limb salvage, but residual plaque in the vessel, which is not a really great outcome to look for a lot of these interventions. We care about how these patients are feeling, whether they're keeping their limb. Then we can talk about stents, and we've also expanded into the deep vein arterialization, which Dr. Lentis approached on. I don't personally do that, but this is used primarily for patients who it's their last outcome. There's no bypass option, they're desert foot, and you do burn bridges by doing this procedure. A lot of times when people do DVA, they come back and the foot is grossly swollen. It looks way worse than it was before, and majority of them do have below-knee amputations. And Dr. Lentis joked around before about the below-knee amputations, but that is an option for a lot of patients, even above-knee amputations. Some of these patients, endo option is the easy one to do. We can try it out, but they shouldn't have open repair because they are nursing home patients with contracted legs or non-ambulatory demented. Then we can talk about open repair, and I think Dr. Han's going to mention a little bit about that, which is the peripheral bypass and the endarterectomy, and the hybrid approach. Again, Dr. Lentis stole some of my slides speaking about that. But the hybrid approach is something that's new, and it's exciting because you can do an intervention and do a below-knee or above-knee bypass and be able to touch up tibials without having to do a distal bypass. So I think a lot of these fem-pedal or fem-distal tibial bypasses are becoming less and less common because we have these options. So endovascular option, we're going to go over some basics, but the contralateral femoral access is typically most go-to for most proceduralists. It requires good access and no calcium. You want to avoid going up and over in patients who have large aneurysms with plaque there because you don't want to embolize. So dissections, kissing iliac stents are my least favorite because they make coming back much harder. And also aortobifemoral bypasses because the angle that the graft takes off from the aorta makes it very difficult to go up and over. In these situations, ipsilateral femoral access is a really good choice. It also requires good access and no calcium. A typical finding that most people have is there's not much running room. So you keep trying to put your sheath in and it keeps sliding into the profunda, and there's some tricks and tips to do on that. Either way, when you're intervening below the knee and treating tibials, it requires support and control. And this comes down to the sheath size and length. Whenever I'm intervening on just the tibials, I want to get a long sheath, either a 90 centimeter or 65 centimeter sheath, sitting right where the tibials are. I want to work with the correct wires, usually 014 or 018, but not 035, because 035 can cause a lot of damage in those vessels, especially if you go into a collateral branch. You can have a perforation that can't be treated. And you want to use the correct support catheters. Now, the rise of this alternative access and toolbox, I think, mostly deals with pedal access. And the thing about pedal access is 10 years ago, people didn't know how to do pedal access. There were courses, and you weren't trained during fellowship or residency doing them. You usually had to travel across state lines to learn how to do pedal access. Now, pedal access is not really an alternate access. It's some people do it primary access. You want to choose your patients correctly. You want these patients, typically I do for rest pain or tissue loss, and I say no claudication, But sometimes I would say if I'm having a difficult time from above, I can do pedal access, but this requires more than one vessel runoff. And now there's the classic Safari, which is an above and a below with a snare of the wire, or just from below. That's user preference. Straight pedal requires some trustworthy imaging beforehand, either a diagnostic angio where you see where you're coming from, or CTA or ultrasound. And femoral pedal, I prefer because it allows real-time imaging of your disease. So if you do atherectomy and angioplasty, you don't have to take your entire device out and shoot a picture. You can just shoot from above and see if you embolized or any other issues. And then this also allows for reliable hemostasis. So when you take your sheath out, you're not bleeding and causing the patient pain in the foot. There's two different ways to access. I used to be a strong believer in duplex, but this duplex access requires a good ultrasound, which in the OR is not always available. In the angio suites, it usually is. And it's typically easier when you do the duplex for either the DP or the PT or the AT. Because you can see it. The perineal is a little bit more difficult and requires fluoroscopic access. You shoot a picture, you road map, and you put the needle in the same plane along the length of your road map. In terms of preparation, groin and foot have to be prepped beforehand. It's a pain in the butt. When you say, where's the foot? And there's a sock, there's a sheet, whatever over it. I get imaging from above, either IPSI and contralateral access. I access with ultrasound or fluoroscopically. And I typically give a radial cocktail solution, which is nitro, heparin, and other variations right into the pedals. This, I think, leads to less spasm in the vessel. And when you take out your sheath, less likely chance that this will thrombose. I attempt to stay intraluminal and snare the wire from above. So this is some imaging of me snaring the wire and pulling through from the sheath for through and through access in a classic Safari way. Excuse me. And then once we're across the lesion, we're ensured that we're intraluminal. It's dealer's choice. You could do plain old balloon angioplasty, DCP, lithotripsy with shockwave, or atherectomy. Now, CSI atherectomy is typically the one that I use because it's for French, so we're able to access it through the tibial access. If you're doing radial access, it's also one of the only devices, I believe, that has a 200 centimeter device, so you can access from above. I don't usually use Hawk as much. Rotarex, I think, is an excellent option, but it's a little bit larger. And then in terms of stenting below the knee, you're not going to be using many of these Illuvias or Zilvers because of the size, but you could use Zion stents or other coronary stents. This is an example of a 65-year-old female, basic medical problems with these vascular paths, left-sided stents, and she had a non-healing ulcer in the right lower extremity with pain in the foot. ABI on the right side shows 0.46 with the TBI 51, a toe pressure 51. So as you can see, the origin of the SFA, this is just the profunda branches are present, but the origin of the SFA is occluded. Even when we shot close, there was no nub, and the wire sheath combinations kept bouncing into the profunda, which is a larger vessel. You see the reconstitution in the mid-SFA and 3-vessel runoff to the foot. So this is a good time to use pedal access because you have good 3-vessel runoff with a tissue loss patient. We did ultrasound guided access to the DP. We maintained the wire from above and below. And like I said, we were able to shoot real-time imaging. And we were able to cross from below and confirm intraluminal position. We did the diamond-backed atherectomy and just angioplasty, reducing the plaque morphology and diameter, and plano balloon angioplasty gave us a good result without having to stent, which is the reason people do atherectomy, to reduce stents. And then this is a pedal access tibial intervention, prior SFA stents, occluded PT, non-tealing TMA site. And so as you see, access from above and below. We see AT that occludes, a perineal is the primary vessel, and then the PT comes back. What we did is stuck the PT, came up, the wire passed very easily, snared it from above, and we're able to do plano balloon angioplasty with good flow into the foot. This is the last example of a hybrid case because I'm running out of time. Open exposure and the treatment with adjunctive endovascular procedures. So this is good for high morbid patients. Like I said, this toolbox is based off patients, not the provider, not data. You have to base it based on the patient who's presenting to your office or in the hospital. So it's good for if you're doing a femoral endarterectomy, you want to stent the iliacs at the same time, or you do a femoral endarterectomy and you cause a dissection plane and your SFA is closed off. You could stick the patch and go down, and you could also improve outflow for your bypasses. So this is a patient, he's 75 years old, ESRD, diabetes, he has SFA and tibial disease, severe stenosis in the iliacs, SFA and one vessel runoff via diseased perineal. So we see this very diseased common femoral artery, the popliteal disease, and there's some reconstitution of flow at the foot via diseased perineal. So we did a patch angioplasty, and as you could see, the SFA remains diseased afterwards, not much flow going into it. So what we did is we did a patch angioplasty, we stuck the patch, ballooned the entire SFA to give us an adequate diameter, and then what we did for below, this is the before imaging of that diseased perineal. We did a 2 millimeter balloon angioplasty, and we see the perineal looks a lot nicer, and for a runoff, that's actually something that's sufficient enough to heal a wound. Thank you.